know and what we don't know. And then I'm also going to sort of apply that specifically to the context of hepatitis C and treatment services. So firstly, I'm not assuming that everyone is familiar with what an alcohol brief intervention is and how it's defined. I think the most important thing here is to recognise that it's a whole range of practices that aim to identify a real or potential alcohol problem and motivate an individual to do something about it. So it includes conversational interventions, but it does also include text-based, online interventions, app-based interventions, and those are a very growing field. I'm going to mostly talk about conversational interventions, though I'll mention briefly the evidence about the others. When we talk about alcohol brief interventions, they vary in many ways, as has been pointed out 20 years ago, and that really hasn't changed since the time that that paper was published. So with that caveat that you're looking at an umbrella group of interventions, we have good evidence for modest efficacy of alcohol brief interventions in reducing alcohol consumption in primary care settings, and also evidence for their cost effectiveness in primary care, or even that they save costs. And the caveat there, I guess, is that those studies in primary care are not, as Ian referred to, in relation to people accessing primary care for opioid substitution treatment. It's people who lots of other comorbidities are excluded in primary care. So we're talking about lots of different kinds of interventions, so I suppose it's not surprising that there are a ton of different acronyms for alcohol brief interventions. We talk about ABIs in Scotland, probably in England they talk about identification of brief advice, and you'll also see lots of other different terms around the world. For today, specifically, I've added in the last one here on motivational enhancement therapy, which is included in the reviews, the sort of systematic reviews of alcohol brief interventions, and I'll mention a bit more about what that includes later, though it's sometimes in the UK considered a form of brief treatment rather than an alcohol brief intervention. A lot of the interventions are based on motivational interviewing. Just very briefly to say what that is, I guess these definitions are from the sort of third edition of Motivational Interviewing, book by Miller and Rolnick, and I suppose the important thing here is that motivational interviewing has changed over the years. The newer models and guidance are probably easier to explain and learn, so if people are familiar with perhaps motivational interviewing from a long time ago, it's worth revisiting that. They are also the newer models based on extensive research about what works and what doesn't work in relation to changing behaviour. So if people are not using the most up-to-date models, it's likely that they're missing out on some of the ways in which they might be able to improve efficacy if they're using brief interventions based on an MI model. The other thing to say is that the Scottish National Alcohol Brief Intervention Programme, which was implemented under a heat target for the NHS in antenatal, A&E and primary care settings, is just one model of ABI, and this is just a comparison between the kind of how we presented and described and implemented alcohol brief interventions in Scotland and how they're generally presented in England. I guess, although this is the way that we've covered alcohol brief interventions in the training in the national programme in Scotland, we don't really know in practice if the hundreds of thousands of alcohol brief interventions that have been implemented have any fidelity to that model, and what actually has been implemented in practice is very unclear. So brief interventions exist on a kind of continuum, and if we think of that continuum in terms of the length of the intervention, you can broadly think about brief advice being shorter, brief interventions being a little bit longer, and the green model there sort of putting the Scottish model in the centre, and the one on your right is extended brief intervention, so slightly longer, more focused on motivational interviewing. So I guess here's kind of a Scotland-centric view of the continuum of brief interventions. But I wanted to point out that screening, these are all brief interventions in terms of the literature, and also the importance of screening within all of these. So screening, I'm sure people are familiar with what that is, but I guess thinking about whether we want universal screening, targeted screening towards certain groups and in what settings, or whether it's opportunistic screening is a question that might be relevant to the field here. I wanted to say a little bit about self-report screening. So screening tools or questionnaires, they rely on self-report. And self-report has historically been considered superior to blood testing in terms of its sensitivity and specificity for assessing alcohol consumption. And that reliability and the studies of that reliability come from studies in alcohol treatment contexts. But it's not clear that the same reliability would apply in settings where people are seeking treatment for a drug problem, and then they're being asked separately about their alcohol consumption. So we don't know if self-report is reliable in that context, and I'm sure people will have strong views about that in relation to their own clients. What we do seem to find, though, is that just asking about alcohol consumption can have an impact in some people. It's likely that those people are perhaps those who would find it the easiest to change their consumption. But even if all you do within a service is screen and find out about, identify a problem, you can then refer on elsewhere for a brief intervention, extended brief intervention, or even brief treatment, like, as I mentioned earlier, motivational enhancement training. So MET in that context could be something along the lines of 30 to 45 minutes, delivered 4 of those sessions of 30 to 45 minutes, including feedback about liver function tests, as well as a motivational interviewing focus. That would still be considered a brief intervention when we think of what's included in the systematic reviews that give us our evidence base for this. Just very quickly about online and other interventions. Most of the research is on internet-based interventions. There's a lot happening in relation to apps and other forms of electronic intervention. And what we find is that the sort of single session online interventions seem to have a small effect. They, of course, rely on people finding the sites, so it's usually first-time help seekers that are finding and using those sites. If we want people to engage in the more extended online interventions where there's a series of modules over 6 weeks, that seems to need at least introduction by a healthcare professional or by another professional, and people are more likely to complete the program, unsurprisingly, if there is some guidance and support. So some of the kind of cheap cost savings of single session SBI can be lost when we look at what is needed to have a greater effect in more extended online interventions, because you still need the input and support of a health professional. There are lots of things that we don't know, and this is a useful review if people are interested in thinking about the sort of whole variety of different cakes that you could constitute alcohol brief interventions, and what are the recipes for those different cakes, and do we know anything about what the actual active ingredients are, so which things must go into that recipe to make that brief intervention work. And the things that we don't know, which I should just skip this just to show you this slide. So the things that we don't know are how the different elements of content work with different people, with different levels of problems. We don't know very much about the differences in efficacy when alcohol brief interventions are delivered by practitioners other than doctors and nurses in primary care settings, in different settings and different combinations and so on. And SIPS is the name of one study that demonstrated that very well. This means, I guess, that for you in terms of thinking about the delivery of alcohol brief interventions for people with hepatitis C, that actually the questions and problems that you're facing in terms of gaps in knowledge are not unique at all to this setting. They are in fact questions and problems that apply to a whole range of settings that are considering the delivery of alcohol brief interventions. And these are other things that we don't know. And that has been highlighted in research. Okay, so moving on then just to think about how you might go about the question of alcohol brief interventions in people with hepatitis C. And I'm often asked about the appropriateness and feasibility of alcohol brief interventions in various different new settings. And so I've been sort of reflecting on some of the research that I've done, my experiences in terms of training and teaching, and generally just hanging around people who are interested in alcohol brief interventions for a long time, as to what are the most useful questions to think about that help you to consider this question of implementation in a new setting. And so I've come up with these 7 questions that I'm going to very quickly take you through. They relate to need, current practice, legitimacy and acceptability, practitioner ability, support needed, efficacy, and what might be needed for routine implementation. And I suppose these questions can also be used to assess the readiness of a given service to deliver alcohol brief interventions. So first of all, thinking about, is there a need for alcohol brief intervention in this setting? And this might seem like a really silly question in the context of what we've heard already this morning when you think about hepatitis C. But I suppose, although it's obvious very much to people within this field that there are alcohol problems and that alcohol is very much exacerbating problems that people with Hep C are experiencing, it doesn't necessarily follow that that's obvious to everyone who's working with people who are infected with hepatitis C. So it's subject to prejudice, the same prejudice that we might find in relation to addressing alcohol in other settings. And people often focus more on those who are dependent on alcohol rather than thinking about people who are drinking like maybe they themselves are drinking. Even in this study, quote from a study I did in a community mental health team, where again alcohol is very much associated with exacerbations in mental health problems, and the consensus of the whole team was that it wasn't alcohol interventions weren't particularly applicable to our clients. So what I'm saying, I guess, is that there's a need to demonstrate and communicate that evidence about need to practitioners in order to, and to managers and to service commissioners and so on, in order to show that there is a need for this service. It seems like with the evidence that you have that's been presented this morning, that shouldn't be too difficult a task to do. What I would say also, though, is the more local the evidence, usually the more compelling. So people may look at national Scottish figures and say, but that doesn't apply to our clients in our service in this area. And so the more local, usually the more compelling. You need to be clear that alcohol is a legitimate focus, and they're expecting that that's something that would be raised in the setting in order for MI to be used effectively. So the third question is about legitimacy. I think if someone is coming into a service that is both for alcohol and drug treatment, it's perhaps easier for it to feel legitimate to raise the issue of alcohol. If someone is attending a service that only deals with drugs, then perhaps there may be more of an issue about how acceptable it is to service users and how much they would expect to be asked about their alcohol consumption. And I think also thinking about what is the main remit of the service, and do ABIs fit with that main remit? For health services, that's usually less of a problem than it is for thinking about ABIs outside of health services. The issue about skills and practitioner skills to deliver alcohol brief interventions probably goes back to what's already happening. So what training do the practitioners in these services already have? My sense is we're probably not training people to do something that's completely new. I imagine that in drug treatment services, lots of people already have training in psychosocial approaches, and alcohol brief interventions are just a psychosocial approach that's specific to alcohol. But I guess it's thinking about whether that those conversations and the use of those skills is drawing on the sort of best available evidence and the most up-to-date evidence in relation to MI, in relation to the ingredients of alcohol brief interventions that are most likely to be effective, and what we are starting to find out about that. Thinking about support, I guess, I was sort of wondering here, I've written down, in many settings people worry about opening a can of worms, and are drug treatment services any different here? So I don't know how well drug treatment services are able and comfortable in terms of dealing with that can of worms. So the can of worms, trauma, domestic violence, poverty, loneliness, stigma, you could go on and on. But if you ask about alcohol and you do it in an MI way, then it's, the whole point of it is that you're looking at what the drivers of that consumption are and helping people to cope and to manage the drivers of that consumption at an individual level, and that is likely to bring up lots of other things. That's definitely a concern for primary care practitioners. So if you were looking at GPs providing alcohol brief interventions to their OST clients, I would imagine that this would be a big issue. Okay, so you could do all of this, show there's a need and design a lovely intervention, but is it likely to work? I think the key thing here is that we can't assume a transfer of efficacy evidence from health settings. The evidence really is only in primary care settings and to a lesser extent in tertiary education settings with young people. There isn't particularly good evidence of efficacy outside of those two settings, and there are some areas where there have been quite a few studies and they fail to show evidence of efficacy. And it seems logical to me that it's unlikely that any conversation about alcohol will work equally well for any person in any setting. There are probably some that are better in some settings and for some people. And I looked into the evidence for alcohol brief interventions in relation to drug treatment populations and hepatitis C, and there are some studies but not very many. So there's a systematic review that included Sharon Hutchinson and David Goldberg as authors, and their conclusions were that alcohol brief interventions could lead to abstinence or a reduction in drinking days per month, and the practitioners should be encouraged and trained around screening and alcohol brief interventions. I think one of the caveats here is that there were very few studies. There were 2 randomized controlled trials. One showed no change One showed an increase in days abstinent, but actually after this systematic review, the same team that found an increase in days abstinent published another randomized control trial where, although they found an increase in abstinence, they didn't find a decrease in consumption. So people were just drinking the same amount, but in a fewer number of days. It doesn't sound to me, from what I've heard today, that is something that would be beneficial. There are also reviews of psychosocial interventions for alcohol and illicit drug users. They included also things like cognitive behavioural coping skills training, hepatitis health promotion versus motivational interviewing, various motivational interventions. So the interventions, like with alcohol brief intervention literature more generally, are very varied. There isn't particularly good evidence of efficacy, but we don't have a lot of studies, and the quality of the studies was sort of low to moderate in the systematic reviews that have been done. I think it's interesting that we sometimes shy away from saying this might just not work, it might just not be worth doing. But actually, with the evidence that we have just now, it's not strongly saying that this is efficacious. That may not mean that there isn't a moral imperative to do something and to have conversations with people and to give them information that's relevant to their health. But investing a lot of time and resources in that, we need to be really careful about whether that will work or not. One of the conclusions from the study saying there, and I just find it interesting that the way this is structured, it's a double negative. There's very little evidence exists that there is no difference in the effectiveness between different types of interventions, and that brief interventions are not superior to assessment only or treatment as usual. So rather than saying there's very little evidence of efficacy, they're saying there's very little evidence that they're not efficacious, which seems kind of strange. So I think I don't want to over-egg this, because from what I've heard this morning, it would seem to me wrong if there weren't conversations about alcohol happening with the patients. So I'm not suggesting that that doesn't happen, but I think it's just being cautious and also bearing in mind, what are the possible harms? And we need to always ask that question. If we're trying to change something, are we sure that what we're attempting to achieve is better than what's already happening? And that's important for evaluation. Okay, so if we think it is important to implement some form of ABI in the setting, then thinking about what will work to make this routine. And I have a sense that there's a sort of a general feeling in your community that would be a good thing if we could establish sort of routine implementation of some kind of screening and conversations about alcohol. From some of the research that I've done in relation to the Scottish national target, a target does help. You have to be really clear that the target is targeting the thing that is the or close to the top priority for those services. So if you have too many targets, then nothing is prioritised, and people just feel under extreme pressure. It kind of becomes a race to the bottom in terms of everything's a priority, so nothing's a priority. The other thing is, I think, learning from the world of implementation science, which tells us a lot about how we can implement innovation in any given healthcare setting. And that's a whole body of work in itself, but there are some very good reviews that give you a whole list of things, levers that you can target in order to try to embed a bespoke intervention into existing systems. So those two things are important. So thinking about what is the bespoke intervention that works best and is most likely to be relevant to your population, feasible, acceptable, and so on, but also knowing the existing systems and where that best fits so that it's as easy as possible for it to become a routine thing for people to deliver. And there's quite a body of literature on that in relation to alcohol brief interventions, but also more generally. Okay, so in conclusion then, and I've changed these since hearing everyone this morning, completely rewrote this slide. So I guess just to be really clear, it seems very obvious that alcohol brief interventions are needed, but we don't really know what works. There is probably a large diversity in terms of the conversations that are already happening, so we could be looking at doing something around ensuring that those conversations are at least informed by the latest evidence, the newest model of MI, and the sort of evidence around ingredients for alcohol brief interventions. But we do need to document that at the very least. Better still if we can evaluate those different models that are out there to learn a bit more about what works and include possible unintended consequences. But really, it seems to me, with the kind of funding that you're talking about to provide treatment for people with HCV, and also the question marks over the cost effectiveness of that treatment that I've also been hearing this morning. The amount of funding that you would need to do some pragmatic, robust research into how best to conduct these conversations and how best to support people to reduce their alcohol consumption would be a fraction of what you need to treat. And if the alcohol consumption is driving a large burden of the morbidity and mortality, then it would seem that that would be a reasonable thing to call for in relation to this topic. Thank you.